name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis, where I'm a professor of radiation oncology, director of clinical trials, and chief of the cardiothoracic and stereotactic radiation services. Many patients will be referred to their radiation oncologist to treat metastases, and one of the most common situations is tumors that have spread from the primary in your lung into the bone. Now, the first thing you should recognize is that around 40% of patients will ultimately develop this problem, so it's not uncommon. That also means we have lots of experience in thinking about how to manage these situations. Now, even though you think it might be reasonably straightforward, as it turns out, the best management of a bone metastasis is complicated and will depend on a variety of things. These can include, but are really not limited to, the fact, including which bone the tumor has spread to, how much pain you're in, whether that pain is primarily from the tumor itself or a fracture of the bone, whether there are other symptoms beyond pain, such as weakness, what overall chemo or immunotherapy or other systemic options you might have, whether you've already received treatments in this area, including prior radiation, and finally, your age and overall health. If we take these individually, the bone that the tumor spreads into is really important. We think of some tumors, some areas of the bone as being what we call weight-bearing or non-weight-bearing. Bones that are weight-bearing, such as the femur, are particularly problematic because you're constantly putting a lot of strain and weight on those areas, and therefore, with spread to the bone, that can cause increased pain, but moreover, they're more likely to fracture. The other question might be how much pain you're in. And if you have a tumor that's spread to the bone, and you have a low level of pain associated with it, and you're overall about to start chemotherapy, it's quite possible that the chemotherapy alone may help you with that pain. So radiation or surgery, other alternatives may not be indicated. The other big question is whether the pain is primarily from the tumor itself or from something like a fracture of the bone. In situations where the tumor itself is causing pain, either by stretching the pain receptors or just growth itself, that's a situation where chemotherapy and radiation can be quite effective. However, if there's a small fracture or even a larger fracture associated with the bone, while radiation and chemo may shrink the tumor, it is not going to inherently help the pain associated with the fracture. And those are situations where we would want to bring our other colleagues on board, orthopedic surgeons or radiologists, to help either fix the fracture with surgery or sometimes gluing it together. The other question is whether there are other symptoms beyond pain, such as weakness. A common situation is tumors spreading to the spine bones. Now, if that happens and the tumor grows the wrong way, it could even press against the spinal cord. And that's a medical emergency, because with further growth, it could make it difficult to walk or sense, so that you have a lot of limitations if that happens further. The other big question is where you are in your overall cancer journey. What other options do you have? Have you just started and you've got 3 or 4 or 5 different possible options ahead of you? Or have you had a lot of other treatment and your doctor's telling you that options are limited? That really plays heavily into what types of treatment we may offer. And as I also mentioned, whether you've already received prior treatment to this area. Many patients have had prior radiation, and giving additional radiation is often possible, but it definitely increases the risk, and it may be done in a different way to reduce that risk. And lastly, your overall age and health. As you might imagine, somebody who's a little bit younger and healthier may have a larger degree of options available, particularly from a surgical standpoint. So that's a lot of different things that go into thinking about how to treat a simple bone metastasis, so not so simple afterwards. Now, the overall options are pain medication alone, chemotherapy or other systemic therapy, radiation, surgery, and then what I like to think of as interventional treatments, often delivered by radiologists, but sometimes by other trained medical professionals. These can include things called ablation, where they can either burn or freeze the tumor, or plasty, meaning that they can glue it together. That can include vertebroplasty in the bone or the vertebral bodies, but it can also be done to other bones as well. Now, focusing back on radiation, there are really 2 main types of radiation that we think about for bone metastases. First is a conventional course of what we call fractionated radiation, where we break the doses up into small doses per day. This is done so that we can get the doses in safely, such that we're not giving such large doses that we might cause harm, but getting enough of that in there to have an effect on the tumor and reduce the pain in that region. Another form of radiation is called SBRT or SABR or SRS. These mean stereotactic body radiation or stereotactic ablative body radiation or stereotactic radiosurgery. They're all really the same thing, just different terms for the same procedure. And that's giving high-dose focused radiation treatment using specialized equipment. Now, overall, conventional fractionated radiation is the mainstay of treatment. Overwhelming the vast majority of patients receive that type of treatment. And there have been many, many trials that have shown little difference between whether you give a single dose or 5 doses or 10 doses or 15 doses. And all of those trials show basically the same thing, that if you can't make a distinction between tumor pain versus fracture pain, the overall pain response rate is north of 60%, meaning more than half of patients will have a good response to radiation. If you really drill down into the patients where it's mostly tumor pain, or someone has done a good job of fixing the fracture-related pain, that overall pain response rate is much higher. It's closer to 80 to 90%. Now, a big question is whether it is maybe better to use the focused radiation, the quote stereotactic radiation in certain circumstances, and it's quite controversial. In fact, there was one recent randomized trial that took a long time to accrue that showed that there was really no difference between a single high dose versus lower dose in terms of short-term pain response and need for retreatment. However, another one was just reported that showed that 2 high doses may be better than 5. So you can see it's confusing to us, and it could be even more confusing to you as well. Now, what you can expect during the course of this treatment is pretty consistent, regardless of the approach that you take. You're first going to have what's called a simulation, where you come in and you lay down and have a mapping of the treatment using a CT scan. You'll have some marks drawn on you to make sure that we can get that lined up at the same way every day. Those are not permanent, although sometimes we will use tiny little tattoos to make sure we can line you up if those marks go away. You'll then come in a couple days later after the radiation doctor has had a chance to make a plan, and you'll lay down on a table. And in general, the whole treatment takes just a few minutes. During the treatment, you don't feel it, see it, smell it, or hear it. Most people don't even realize that the treatment is even completed at that point. And you'll repeat that anywhere from 1 to 15 times, depending on how your doctor prescribes it. During those treatments, there's a couple things that can happen. The first is you could develop some fatigue. That's pretty common with just about anything we do to you in the cancer world, but certainly can happen with radiation. You may develop some redness or dryness of the skin by the end of treatment, and that may last even for a few days or weeks afterwards. Very rarely is it more than that. If necessary, we can give you skin creams. About 20 to 30% of patients will develop what's called a pain flare. That's where your pain actually gets temporarily worse before it gets better. And we're not sure why that happens to some patients and not others, but if it does happen, you can often take some steroids or some additional pain medication until it gets better. Anything more serious than that is very uncommon and would really depend on where we're treating. So if we're treating something, a bone that maybe requires us to go through the bowels, you might get nauseous or have some diarrhea. If we're treating up near the throat, you could get a sore throat. All of these things tend to be manageable and temporary, and overall go away quickly after treatment. And overall, most patients have a good pain response. So it ends up being a nice balance in the grand scheme of things.